Thank you so much for that introduction. It was great coming early because I got to meet colleagues at RAP. So thank you to RAP for inviting me to speak on this important platform today. I know there are many economists, health economists, people who have worked at the district health level. So my talk today feels like I'm going to be preaching to the choir, but just based on the aspects that Russell mentioned, I think important to set the scene for today. Okay, sorry. Yeah, so not a good idea being the first because you learn all the technical, the ironing out begins with you. Okay, no worries. Just let's see. Okay. So as Russell mentioned, South Africa faces a persistent burden of disease in the context of tight fiscal constraints and the high spend on health, 8.8% of GDP. Recent data highlights that the burden of disease in low and middle income countries is rising faster than GDP growth. Data from health economists in the country, as some of you may know, Michael and team at Priceless, highlight that the economic cost to the health system for conditions such as mental health, obesity, and overweight in the range of 5 to 15%. And more recently, data from the Bushbuck Ridge area demonstrates the high out-of-pocket expenses incurred by patients with 2 or more conditions. And these are patients accessing free public sector services. So these are the indirect costs. So shifting these rural households deeper into poverty, of course. So Russell mentioned today, my goal is to reiterate the economic investment case for prevention. So there's a strong economic case for shifting resources upstream to prevention and early management, especially early in the life course. The shift is not simply an aspirational one, it is economically necessary. So it's recalibration to protect the sustainability of the health system. Prevention avoids the need for more expensive downstream services, such as avoidable admissions, preventing complications, and improving overall population health. Early detection and management of chronic conditions reduce long-term costs both to the health system and the household. Without a prevention-first approach, the system will be forced to absorb higher costs, worsening inequities, and declining service quality. Evidence-informed prevention investment choices for benefit design under the NHI is critical. The package needs to be assessed based on what delivers the highest health return per rand and advances equity in underserved communities, which is no easy task, as you may know. So now, going down to the district. So prevention makes economic sense for the district. Prevention and early management consistently offer higher returns on investment across multiple health areas. By intervening early, whether through community-based screening, routine PHC level management, or behavioral prevention programs, the health system can avoid costly hospitalization and long-term complications that escalate expenditures. For districts, this means reorientating services away from a hospital-centric model towards strong primary health care and community structures. Furthermore, preventative interventions restore productivity by reducing morbidity and preventing disability, thereby generating economic gains not only for the health sector, but also for households and the broader economy. And these gains, of course, compound over time. As shown by health economist Funeka Bango and team UCT colleagues, there's a high upfront cost often with preventative programs, particularly if you are targeting early in the life course. And we see that across many other programs in LMIC. However, Those potential high upfront costs are often offset by costs later linked to serious SRH complications, linked to teenage pregnancy and school dropout. The return of investment for mental health prevention and treatment is clearly demonstrated in modeling work done by health economist Donella Basada and team at the SMRC, particularly highlighting the return of investment for school-based mental health screening programs, as well as for screening for common mental health disorders. Their work shows how shifting mental health services more towards community and PHC models of care can free up resources to manage and treat the more complex cases within inpatient care services. So if we did nothing about prevention, what would be that cost for inaction? So failing to invest in prevention, as you know, is far more costly than delayed diagnosis and treatment. Across diseases and population groups, the economic costs of unmanaged conditions are linked to loss in productivity, disability, preventable complications, and catastrophic household spending, which far exceed the cost of implementing targeted preventative programs. Data on the right show that inaction around youth SRH needs or mental health prevention in this population can cost the state an estimated 8 to 4% of GDP per annum, crowding out budgets for other needs. When districts defer early detection or underfund PHC capacity, they pay later through emergency admissions, advanced disease management, and expanded social welfare needs. The pay later and more cycle leads to budget pressure, worsening inequity and lower quality of care as highlighted. The bottom line is, inaction is the most expensive policy choice. By investing early, districts prevent cost escalation and ensure resources are used where they deliver greater marginal benefit. So how should district level health systems go about priority setting? So districts need clear evidence-based processes for choosing which interventions to fund. But how do we get there? How do we support district managers? So the first step would be to begin with local disease data and to identify the high impact areas. Use cost effectiveness evidence, although we know it's quite scarce in our setting, to rank interventions by health gains per rand spent. Apply equity lenses to ensure investments prioritize rural communities, low-income households, and vulnerable groups. And align district choices with national financing reforms, including the future NHI purchasing rules. District managers should be able to answer simple questions around priority setting. Which intervention offers the highest value? Which populations benefit most? And what can we afford now? And how do we measure progress? By adapting transparent, structured decision-making tools, districts can build trust and ensure budgets are allocated to high-value interventions and reduce inequities and increase system resilience. Emerging data-driven platforms that are being developed, such as the evidence to decision collaboration with the MRC and NDOH, is one such platform with the hope that district managers would tap into to understand what the evidence is showing around effectiveness and cost effectiveness. But it also involves including voices that are often missed in the health policy and research space. So much of this work also currently being done in the country around looking at sort of district priority tools being adapted for the setting, particularly rural communities, as shown by colleagues at Priceless for prioritization of community needs under the NHI. So as a health economist and someone who's worked at the district level, we know that it's not all about money. I think we all know that key towards district level priority setting is the strengthening of our governance and district level capacity around this. And of course, promoting resilience in our health systems. So when we look at governance, as colleagues have a study in press, and they have shown sub-districts are operationally central to primary healthcare delivery, as shown in their work in Ghana, but institutionally under-recognized. So modest delegation of financial and managerial authority can also unlock prevention performance gains. Work done by Lucy Gilson and team at the Health Policy Unit at UCT, they did a lot of work around resilience, and what they show is stable governance structures and adequate resources do influence everyday resilience, but they're not enough to sustain the health system. Instead, it appears important to nurture the power of leaders across every system and to help them reframe challenges. Their work shows that much of the district PHC level managers, much of their time is spent on managing complex HR issues. And of course, from a health economics point of view, that's taking up time by an important cadre. So just important to note that it's not just, priority setting is not just about getting the budgeting, right? It's also about looking at these other aspects of the health system, the software needed to sustain it. So I'm sure colleagues are going to go more into this, but just a quick brush over the high value interventions for district packages. So we know from the work done in the field of HIV/TB, scaling up integrated community models of care, such as mobile clinics, school-based services, and CHW programs deliver strong returns, and expanding equity, especially in rural and under-resourced districts. So a critical vehicle for that. Russell and team and colleagues at the MRC did this earlier study looking at the CHW program and showing how minimal in terms of PHC expenditure per capita, that sort of program and the returns on that. Other high value interventions, as we know, the integrated chronic disease model package. So improves patient experiences and frees hospital capacity. So costing of the integrated chronic disease model by Labina and colleagues was done in 2 districts in South Africa, Gauteng and the Northwest. And they show that there's fairly low average cost per patient visit, and that can be further reduced by examining the context in terms of implementation fidelity, number of patients accessing the services, and staffing costs related to the WBOT system. So we know we have an idea in our basket of sort of the high value aspects, what works, but how can we finance these and also look at integrated solutions for NCD management? So a large part of that is really about financing it through strategic allocation of existing budgets and maximizing efficiency gains where we can. So districts can achieve sustainable, substantial savings by shifting resources, as we've seen in the HIV/TB world, in terms of human resources, but also shifting it away from low-value inpatient procedures towards PHC and community-based models that allow for wider access and reach of hard-to-reach groups. It also involves some intersectoral budgeting. Work done by Gitesh and team at UCT and the MRC also show how innovative ways such as the private-public partnerships can help fill important human resource gaps in rural districts, especially around obstetrics care. As colleagues have mentioned, with the withdrawal of donor funds for community HIV programs, we also need to look at how we sustain the informal caregiver economy, which we know plays a major backbone in much of the HIV/TB programs and of course, the growing NCD burden. And recent work in the field is also looking at our aging population, the need to extend financial risk protection models of HIV care to other NCD and geriatric populations. Colleagues have shown there's oftentimes higher financial protection for those aging with HIV versus those without HIV. So I won't go into this, as I'm sure it's going to be the highlight of today, but Michael and team at Priceless have looked at this. And so the health taxes, of course, as you know, is the space that can help finance these innovative district health models. The revenue generated from sugar-sweetened beverages, tobacco, and alcohol not only reduce harmful consumption, but allow for that revenue stream that can be reinvested into our prevention and early management programs. As shown by colleagues in Priceless, just the tax on fruit juice alone, the substantial impact it can have in terms of savings on healthcare expenditure. Another key aspect to how we finance prevention is, of course, strengthening our district level data systems and supporting supervision at all levels. It enables to track the spend to impact and ensure funds are also protected even during periods of budget tightening. Prevention financing must be coupled with accountability frameworks so districts can demonstrate measurable health and economic returns. And alongside that, we need to support the use of our data systems, so to inform sort of the robust healthcare financing decisions that we have to make. And we need to leverage both our routine as well as our surveillance systems for district level planning. And we know South Africa has a landful of data systems in the country, and it's also about harmonizing across platforms. And lastly, there's a need for more locally based health economic tools. I think health economics in the field in South Africa in particular is faced with a challenging sort of period right now. We ask big questions, but we lack the basics in terms of tools, from quality of life weights to cost effectiveness thresholds, and to integrated financing models that can be used to sort of inform decision making at the various levels. And so there's a need to invest in that. And so in conclusion, so prevention is smart economics for the district. It saves money. District managers should see prevention as an investment portfolio, low cost, high yield interventions that when combined, they transform health system performance. Prevention and early management are not optional. They are the most economically rational choices for South Africa's health system, particularly for your underserved communities. A prevention-first PHC district model improves population health, protects households from financial hardships, reduces health system costs, improves equity and resilience. More importantly, it meets the health needs of the present and future populations. And lastly, to facilitate the district level priority setting that we hope to see in the future, we need to develop the financial governance and health economic skills of our managers on the ground. Thank you. I'd just like to acknowledge my staff, students, and our participants and the DOH and community funders. Thank you.